Good afternoon and welcome to today's SAMHSA-sponsored webinar titled Building Hope, a Journey Through Crisis Residential Services on behalf of the National Council for Mental Wellbeing. Today's presentation will be recorded, and the recording link, slides, and a certificate of attendance will be sent via email to everyone who attended today. Closed captioning is available and can be viewed by clicking the CC icon at the bottom of your screen or clicking the link in the chat pod to view in a separate window. We also have an ASL interpreter who should be seen spotlit on your screen. During the presentation, please add your questions and comments in the chat box, and questions will be asked out loud for the presenters to answer at the end of the presentation. When the presentation ends today, a brief survey will show in your browser. Please take a few moments to complete that for us. Thank you again for joining us, and we'll begin our presentation.
Thank you, and good morning or good afternoon, whichever time zone you may be in. I'll start by introducing myself. I'm Ilan Javanfard. I am in Los Angeles. I'm the Division Director of Residential and Substance Services for Didi Hirsch Mental Health Services, and I've been working in the field of crisis services for roughly 10 years as a clinician and as a consultant as well. My co-presenter is Josh Grand. He will be introducing himself when we move into some additional content as well. We want to make sure that we get started with going into some of our learning objectives that are going to be important for what we are going to discuss today. So learning objectives that we hope to be able to achieve in the time that we have together will be to gain a better understanding of crisis residential services as a model as a whole, to gain better understanding of the implementation for partnerships, scaling, funding, and sustainability of residential services, and to understand better how residential services of all types are managed, are staffed, and how they are operated on a day-to-day basis as well. To level set what we are going to discuss today, I wanted to start out by just sharing a brief, quick story. There's this man walking down the street, and he suddenly falls into a hole. The hole is so deep, and he's struggling to get out. And as he begins gasping and struggling to be able to make it out of the hole, he looks up and sees a doctor walking by, and he yells, "Hey, doc, I'm stuck in this hole. Can you help me?" So the doctor writes a prescription and throws it down in the hole and moves on. The man continues to feel desperate in the hole and looks up and sees a spiritual advisor walk by and says, "Please, can you help me?" So the spiritual advisor writes a prayer and throws it down into the hole as well. Man starts to feel more and more desperate, more and more despondent, more and more in crisis, and looks up and sees a friend of his walking by and says, "Hey, Joe, I'm stuck in this hole. Can you help me?" And all of a sudden, Joe jumps into the hole, and he says to him, "What are you doing? Now we are both stuck in a hole." And Joe responds and says, "Yes, but I've been here before, and I know the way out." While that story comes from the TV show West Wing, which happens to be my favorite show of all time, and was written beautifully by Aaron Sorkin just for an episode about PTSD, I think that very much embodies the crisis system in terms of residential care. What we're looking for under this umbrella is a safe place for help that is directly there to help de-escalate the person's symptoms, distress, and also bring them back to their previous level of functioning prior to their crisis. The goal of the crisis system overall is to help uplift the individuals. The goal of residential services in many cases is to help bring the person back to their previous level of functioning prior to that crisis occurring. These places within the United States continuum of mental health services have many different names. And while we will discuss the nuances of different types of these programs throughout the course of this webinar, I did want to place on this one slide here a little bit of an emphasis of all of the different types of names of these services that you may see. They may be called crisis receiving centers, crisis stabilization units, crisis residential programs, crisis programs, or even peer respite programs as well, very much falling in line with that story analogy I shared earlier of a person who's been in that place similar to you in the past as well. So while we will discuss the differentiation between many of these terminologies, we did want to make sure to embody how many of these systems are all there for one purpose, to be a safe place for individuals to gain help and keep them out of alternative locked facilities or facilities that are hospitalizations or jail. So let's move forward a little bit more into a little bit of information that many of you who are joining us already are aware of. We're looking at here the national guidelines for the behavioral crisis care system. The idea behind the guidelines, ingenuity that it was, is that there would be a place for someone to call, someone who would respond, and a safe place for help. Many of us are aware of the abundance of 988 resources that have come to pass, and how 988 is expanding and growing and offering an immense amount of support to individuals when they are calling. Someone to respond are the mobile crisis units and the mobile crisis teams that have found themselves being a safe haven for individuals and supporting them rather than them needing to end up in a higher placed setting. And lastly, a system that we're discussing the most here is a safe place for help. These can be anything inclusive of the 23-hour observation units, such as crisis CSUs. And this was what was listed within the typical guidelines for behavioral healthcare services. Now, as we move forward, we wanted to do is discuss a little bit more on the next slide about the roadmap to the ideal crisis system as well. That you find a person in crisis, and while they are in that crisis, there are several other alternative locations that are considered safe places for help for them at times, depending on the level of the crisis they're in. We're aware of the crisis call centers. We're aware of the mobile response units as well. But we wanted to include in that place to go the possibility of all and everything in between. For people, on some occasions, a psychiatric hospitalization may be the place for them. And for other people, the emergency room may be where they needed their support. But the inclusivity of 23-hour observation units, crisis residential treatment, peer respite programs, crisis centers, and behavioral health urgent cares is an additional aspect of safe places that build up this continuum of care. That instead of allowing us to just place the individual into one specific setting, we diversify the settings and offer more opportunities for people to be placed in an environment that makes them feel most safe, most dignified, and most likely to achieve quality outcomes of care. At this point in time, I'd like to pass it along to my co-presenter, Josh, to introduce himself and go a bit more into some of the content as well.
Hi, everybody. Thanks, Elon. My name's Josh Gran. I'm the founder and principal of Giant Steps Consulting. Before I started Giant Steps, I spent a decade as a leader in the growth of People USA, or formerly People Incorporated. We were an innovative, peer-led mental or behavioral health nonprofit organization, as well as a service provider. I had the privilege of being able to grow People USA and also to work as part of their consulting division with organizations all around the country. So I come from a background where we were very focused on creating services and systems level improvements that were designed to reduce preventable hospital utilization, something that we'll be talking about today, reduce unnecessary criminal justice involvement. One of the great advocacy issues of our time is that we deinstitutionalize old state hospitals, and then people really ended up on an inverse relationship, entering our criminal justice system, which is worse in so many ways too. And so we've got a lot of work to do as a nation and a system to address that. Ultimately, I think a lot of my work throughout my career has been how to align with the triple aim, how to make sure that people have really great care experiences, they have tangible outcomes, and that our healthcare system runs efficiently. So I had the privilege of starting along with a core team, the first crisis stabilization center in the Northeast, and also replicating crisis respites all around the nation. So I wanted to talk a little bit on the next slide about how these sort of work and slot into that system that Elon was talking about. So for a person that is experiencing a crisis, they can self-refer directly to peer respites, and we're going to talk a little bit about what that means. But you can also situate them within that community-based crisis continuum of care, right? So you have your 988, someone to call, you have your mobile team, someone to respond, and then you have your crisis stabilization centers, maybe as one potential someplace to go. But sometimes people can't really get to a level of comfort and stability within 23 hours and 59 minutes. So there are short-term crisis residential services beyond that. One such thing is the peer-run crisis respites, which we'll be talking about today. And then, of course, there's higher levels of care in community as well that are community-based, as opposed to maybe a traditional hospital where you have a more integrated care and multidisciplinary team of traditional clinicians or medical staff. What we're talking about today is what it means to be sort of a peer-run alternative to the traditional system of care. And so some key terms on the bottom: types of respite services. There's living rooms, right? And those are day respites. There's the type that we're talking about today, peer respites, which are overnight stays. And then there's the intensive type. And so there's types of respite services, types of short-term crisis residences. And I think that if we look at it this way, you can see how it relates to what Elon was talking about. And now we can start maybe learning now that we're all on the same page of how this slots into various ways of doing things. Now, again, it's very important to know that these were developed by peers, sometimes called consumers, sometimes they refer to themselves as survivors or ex-patients. And so it comes from a grassroots sort of civil rights movement. So it's always important to kind of remember the history of it and think about, why were these created in the first place? They were created to be alternative models. Next slide, please. So I'm going to be talking a little bit about how to develop these and what that looks like. So I'll give you a little high-level overview of what peer respites are. We'll talk about some of the research determining the need in various communities, the goals for developing these. Again, I like to sort of align with the triple aim. I think it's a great barometer for us. The quadruple aim is also very important as well, where we add the fourth component, which is staff wellness, which unfortunately maybe we don't spend enough time focusing on, but I think the greatest organizations in our field do. The goals for the service delivery: how to identify key stakeholders to develop a respite, funding and sustaining them. And I'm going to talk a little bit about Medicaid waivers today, which, again, we'll talk about maybe some of the controversy surrounding that and some of the opportunities that exist there as well. Creating an integrated crisis system, which is very important, and then how to manage these types of projects. Next slide, please. All right, let's go. Next slide. So identifying key stakeholders to develop a respite. I originally had this farther into the presentation, but some of the reviewers thought that maybe we should start with this slide and then we'll catch up to it later. So the lead organization, it can be ideal to have a peer-run organization. Again, peer-run, consumer-run organizations are defined as organizations in which people with personal lived experience, that could be with mental health issues, crisis, moving towards recovery and wellness out of that, make up the majority of the staff and board. And that's ideal because what you're really ensuring is an unbreakable alignment with the original intent of the model, the service's core values. It says outlined above, but we'll get to that next. The spirit of innovation, I think that's really important. These were designed as grassroots bottom-up solutions to major systems issues. So it's always good to keep that in mind. And most importantly, you want to make sure that you're always aligning with the interests, and that's learned through that peer support and expressed through advocacy of the guests, the clients, consumers, survivors, ex-patients, however people define themselves. It's always good to keep that in mind. Now, these can also be peer staff programs with a non-peer organization, right? And so it's always important to think about, though, what those challenges are, and so that can present a challenge adhering to that fidelity that we've outlined slightly above. But the solutions also lie, in thinking about that upfront and creating policies, procedures, and practices. And you got to reinforce that by training and supervision that creates safeguards or guardrails there. So it is possible. I've seen it done well. So next slide, please. So a high-level overview of peer respites. This is really my type of definition that I've developed over the years, and then I'll talk about a consensus definition on the next slide. They're home-like alternatives to using hospital psychiatric emergency departments and inpatient units. Primarily the inpatient unit, if you're going to situate next to a crisis stabilization center, that would be the ED. But again, folks can self-refer into there, so it can be an alternative to that as well. They're short-term crisis residential models. Typically, people will stay 1 to 7 days. Sometimes they'll go up to 30 days. They're managed and operated by peers. So that's really important that we remember that that's staff with personal lived experience with mental health issues. But it's also important to say that these staff are highly trained and skilled. I think we're hopefully revolving out of this era where we thought of peer specialists, peer staff as paraprofessionals. Sometimes, when you go to an integrated care team and you see peers working in multidisciplinary units, you cannot tell who's a peer and who's not a peer. So it's important that we recognize their contributions to the field. They're open, accessible 24/7, 365. They're 100% voluntary. I know that sometimes that can be what shocks the public a little bit, but guests can come and go for appointments and jobs, etc. They reduce preventable hospital utilization when it's safe and appropriate. There's services, environments, outcomes built on core values. And they can be more cost-effective than the traditional system of care for individuals who are safely able to manage outside of an inpatient setting. So next slide, if you want to see the consensus definition, Leisha Astra and Bevan Croft are very well-known researchers in this specific field. And, they surveyed all of the providers of these types of services throughout the country, or almost all of them. And what they found was peer respites are voluntary short-term overnight programs. They provide community-based, trauma-informed and person-centered crisis support and prevention 24 hours a day in home-like settings. They're staffed and operated by people with lived experience. They're designed as psychiatric hospital diversion programs to support individuals experiencing or at risk of a psychiatric crisis. So the premise behind them is really that psychiatric emergency services can be avoided if less coercive or intrusive supports are available in community. And I really love the mission statement here. Imagine experiencing emotional crisis as an opportunity for growth and change. Imagine a home-like place where you can safely explore that opportunity. Imagine people there for you when you need that support. Imagine they understand and believe in you because they've been where you are, echoing what Elon was saying before. So the power lies in that sort of mutuality between the staff and the people coming there, people that have walked similar journeys before. And it's a very powerful alternative, and people are always shocked to see and hear that they work. So I do want to talk a little bit on the next slide about that. Some of the research on the topic. In full transparency, the first research topic there was involving my old organization at People USA, where we were analyzing the care experiences themselves. But what we found was that services at the program were more client-centered and less restrictive than the traditional system of care to the people that were being surveyed. The staff reviewed as more respectful, decreased stigma due to mental illness after receiving services, good life satisfaction and social involvement levels. Medicaid expenditures in the second study were on average $2,000 plus lower per Medicaid enrolled month. So you see that this ends up saving the system money as well. So which is a secondary sort of win. People experience fewer hospitalizations, lowered rates of Medicaid spending. So that has a sort of system level impact. The third study by Bevan Croft there, you'll see her again, the odds of using any inpatient or emergency services after program start date were approximately 70% lower. Longer stay and respite was associated with fewer hours of emergency service or inpatient units. Next slide, please. this is one of the earlier findings, which was from a consumer survivor-defined alternative psychiatric hospitalization. Persons with access to the program experienced significantly lower psychiatric hospital costs. And when all specialty mental health services were included, access to the program still associated with lower treatment costs. So basically what you were saying is like, okay, after they stayed at a respite, we tracked them over time and they were spending a considerable amount of money less than people that in the control group, which showed that these services might have sort of functioned as a turning point towards a pathway to more health and wellness. Next slide. So how do we determine the need for peer respites? I think there's a great resource out there that a lot of people don't necessarily know about. Was created by the Crisis Now initiative, which is led by the National Association of State Mental Health Program Directors. It was founded alongside with the National Action Alliance for Suicide Prevention, 98 Suicide and Crisis Lifeline, National Council for Mental Wellbeing, and RI International, which was formerly known as Recovery Innovations, folks that run a weekly crisis talk or crisis jam, as they call it. So RI International worked with McKinsey Health Institute to develop this crisis resource calculator. So if we go to the next slide, I'll kind of show you what that looks like. So what you can do is you can zoom in on any county or city in the United States, and it will sort of estimate how much resources you would need to provide. And what they do is they break it down into they look at the population and they'll break it down into mobile crisis teams, crisis stabilization center capacity, short-term crisis residential services. And also they'll think about, once you have those things in place, how many emergency department or inpatient beds would you still need? And that, we don't quite know what that number is. If we had a really great system of care, we might be able to reduce that down very, very greatly, if not even, hopefully maybe evolve away from those types of systems, but who knows? But if you look at the United States, and I like to zoom in, like Elon's from Los Angeles, I'm from New York. I like to zoom in on the middle of the country, let's say. So if we zoomed in from the United States to Kansas to Wichita, you'd see that the United States has a population of 327 million, Kansas 2.9 million, and Wichita is Sedgwick County, and you can zoom in the county level on here. And what you would see is that's a population of about 500,000 people. So what their calculation showed was about the crisis residential services, right? If we're talking about after a crisis stabilization center, where would people go if they needed more than 24 hours of care? You need about 20,000, I'm sorry, you would need about 15,000. If we took half of that capacity, 15,000 respite capacity in the United States. In Kansas, you might need 136 crisis respite beds. And then in Sedgwick County, where Wichita is, you would need 24. So that would mean that if you had enough peer respites where you had 24 beds, you might be able to take half of all of the capacity for short-term crisis residential there. And then maybe people might need a higher level of care. So that's a conservative estimate, half, again, 15,000 throughout the United States, 136 in the state of Kansas, and 24 in Wichita. So just to zoom in and say, okay, how does capacity work? 24 beds for about 500,000 people there. Next slide, please. So when we're developing peer respite, what are our broad goals? Well, again, this is just my own personal philosophy, but I like to align with the triple aim, which is a population health concept, improving the customer care experiences for people in crisis, helping people achieve better health and wellness outcomes over time, reducing overall healthcare spending or public costs, and then secondarily, reduce preventable hospital utilization. Next slide. So high quality care experiences, what does that mean? Well, I think it's important that you build your services and then your environments on a foundation of core values, right? So the core values for your customer care experiences means that things are welcoming. Your communications is person-centered. You're strength-based. You're looking at everyone's, you're not looking at people's deficits when they come in. You're looking at what you can build on as strengths. Because so many people in our system have been very traumatized by a negative focus on what's not working. And so it's good to always flip that paradigm and think about what is working, and how can we build off of that. It's important that these services are empowering, that they're educational, that they're helpful, that they're compassionate, they're supportive, they're positive, they're inspirational, and they're focused on recovery from mental health issues. You know, that recovery from a health issue doesn't just apply to physical health or medical care. It applies to mental health issues. And the staff that work at these places are the absolute evidence of that. Wellness focus, well, I'm going to come back to that soon. And also peer and consumer driven, right? What does it mean to be empowering in that way? And then the environments, if you see on the right there, there's a normal living room. That's exactly what they look like. Warm and inviting decor, comfortable furnishings, it's personalized, it's natural elements, sunlight coming in, quiet and private spaces when you need it, kitchen and dining areas where people hang out and converse and cook together, safety and accessibility, homely routine, right? That's the most important thing I want to leave off here. Creating that feeling makes sure that people don't feel that when they're in crisis, something unusual has to happen to them. They can work on their health, they can work on their wellness in a normal routine. So that's very important. Next slide, please. So I think it's very important that we focus on wellness outcomes. I want to give a shout out to my dear friend, Peggy Swarbrick, who developed the 8 dimensions of wellness for SAMHSA. But I think it's very important to track these types of things over time. And one thing that we did at my old job is we looked at all wellness barometers, you know, physical, emotional, social, occupational, intellectual, financial, environmental, and spiritual. And we said, if we looked backwards, 30 days leading up to somebody's respite stay, what did that 30 days look like? And if we looked forward 30 days and then asked them the same questions again, what did 30 days after a respite stay look like? So what we ended up using was a tool that Peggy Swarbrick, or Dr. Swarbrick, recommended, which I gave a little screenshot on the bottom, the Public Health Surveillance Wellbeing Scale, which I believe was developed by the CDC. And it gave us some really amazing outcomes to look at, where, you know, maybe if people felt healthy and full of energy for a certain amount of days, let's say 9 days in the month leading up to it, it was over 15 days in the month heading forward. So we saw that, wow, when people can reset and really focus on themselves, even in crisis, use that as an opportunity for positive growth, people will start kind of moving towards feeling better in a holistic sense. So I think that's really important to think about. Next slide, please. So, I think there's significant cost savings here. I just created a sample budget here. I used Dutchess County, which is near my house. I live in Ulster County, Kingston, New York, but Dutchess County is sort of our more populated center, and I used Poughkeepsie, New York here. And I used some cost assumptions here, and I built some pretty robust budgets here. And I did one with a real heavy transitional care component, where you could really kind of bridge people out of these and back into the community, or without it. And you'll see over 60% cost reductions here when you use the crisis calculator that RI International and McKinsey developed to look at, what is an average acute psychiatric inpatient bed stay. It's about $1,295 a day versus, $375 to $430. So it's just interesting to look at how these alternatives save the system drastic amounts of money. But that's not why we do it. It's a secondary benefit to it. Next slide, please. So the goals for service delivery, I think, are pretty simple. Although, I mean, there's nothing simple about how you execute it, but we want to foster self-awareness and understanding, like sort of what caused the crisis. Learn about skills and supports and resources for addressing these in the future. Exploring the relationship between the crisis and people's whole health is very important, because the more you learn about people, the more you engage with them, the more you realize that that's where, the truth lies, is that we are holistic beings, and that could be socioeconomic issues, whatever. Problem solve, you've been addressing some of the underlying causes. You learn about and engage in activities that promote and improve health and overall wellness. You connect with services and supports within the community, and you help people ensure a safe and comfortable transition back home. Next slide, please. So you can turn your goals into menus of services, I was thinking about this, our local partial hospitalization program was always using these DBT self-help skills books as for resources, and they're designed for people to read on their own, and that could be something that you offer people to learn about, or run a group, learn about skills, supports, and resources, DBT self-help skills, or learn about engaging activities that promote and improve health and wellness, relaxation and stress reduction techniques. Maybe we're going on walks with people. There's all sorts of things you can do to create a menu of services there. Next slide, please. So it's important, if we go back to our original point where we're talking about, all right, we want to develop these things. Who are we engaging? Well, we're engaging peer-run organizations, or we're engaging traditional organizations where they have peer-run components to it. But it's very important that you engage the whole continuum when you're developing these things, because people need to know that they're there. The crisis response system needs to know that this is an option. And then you need to connect people into the ongoing services that they may need. And that goes beyond just, mental health services. It could be care management. It's your peer advocacy and support organizations. It's your housing services. It's social services. It's employment programs, continuing education. And then it's also obviously very important to have your funding partners involved too. That could be health insurance providers, government agencies, private and corporate foundations, individual donors, and community foundations. So there's additional stakeholders also to consider there, where emergency medical services, educational institutions, veteran services. That is in small type, not to minimize it, but because we ran out of room on the slide, so don't read into that too much. Next slide, please. So funding and sustaining the service, Medicaid as a potential road forward. I would just say, while Medicaid is a potential way to fund and sustain peer respites, it's important to note that many peer-run organizations and advocates are opposed to that idea, because the requirements for Medicaid compliance and billing can make the model feel more medical model, can make the services less flexible. It can create administrative work that interferes with service delivery. And it can create some conflict with the peer and recovery movement. And it can add staffing requirements that prevent the model from being 100% peer run. So it's important to think about and address these issues up front in planning. But there's all sorts of ways to kind of slot these in. There's Medicaid state plan amendments. There's 1115 demonstration waivers. That's something that I'm going to explore a little more moving forward here, as my experience was deeper in that. There's 1915 HCBS waivers, and then there's 1915 state plan HCBS options. The first two are definitely the more ideal ones. The potential for peer respite is higher in those. And so we're going to talk a little bit about 1115 demonstrations, and that's designed to test approaches that could be experimental, pilot, or demonstration aimed at improving health outcomes, reducing costs, and expanding access to Medicaid. The broadest flexibility for states to experiment with Medicaid delivery and financing. States can design and test new service models, payment schemes, and eligibility criteria. It requires a detailed application reviewed by CMS, focusing on alignment with Medicaid objectives and budget neutrality. And I'll talk about that moving forward. Typically approved for 5 years with extensions. And then it has a high potential to really work for peer respite due to the broad flexibility and possibility to assign demonstrations specifically targeting mental health crisis services, including peer respites as a key component. Medicaid state plan amendments are also very flexible, but they vary. They vary by state, and so you have to make sure that your peer services are recognized and peer respites are recognized by your state. But it's always good to get things into your state plan amendment if you think that you want them for the long term. Next slide, please. So, Medicaid waivers are exceptions granted by the federal government to states, allowing them to design and implement specific services. They offer people flexibility. Peer respites are very enticing in this regard because they can reduce hospitalizations and reliance on intensive treatments. They can improve mental health outcomes for people experiencing crisis, and they're cost effective, right, as we already outlined. So 1115 demonstrations, again, they're about experimenting, piloting, demonstrating projects. And what they're ultimately about doing is, you have flexibility as long as it's budget neutral. And I think what you saw in my previous slide where we looked at some of the, cost comparisons, they can be beyond budget neutral. So they're really a nice way to do it. Please, next slide. So, again, I went through this already on the smaller slide there. So I think we can skip this now. Next slide, please. So this is, there's a step-by-step process for getting 1115s. What you do is you build a stakeholder coalition. We talked about who should be kind of leading those and who should be involved in that. You design a project concept. You develop a comprehensive project proposal. You highlight innovation in the triple aim, especially hospital diversion and major cost savings. You work to align with the state and federal priorities. You engage with state officials throughout that whole process. That could be state Medicaid, state mental health, policymakers, et cetera. And then once you have all parties on the same page, you submit a waiver application and you work with the state to revise and finalize. But it's also very important that you create an integrated system of care. And that means building a crisis, preventative, and follow-up system that the peer respite sits in. So we had success with this in New York. And, we have a rate code now, 4625. The description is residential crisis support. It's a crisis intervention waiver. It's a per diem rate, which I think that, if you wanted my honest opinion, when these work well, it's with a per diem rate. When they tend to not work well, what I've seen all around the nation is when you're trying to make it somehow billable units that are smaller than that, because it's too much administrative bloat, perhaps is the word. I don't want to, that's just my opinion. It's not endorsing anyone else's opinion here on that. And then we've got downstate and upstate rates. And downstate is obviously closer to New York City where things are more expensive to operate. Next slide, please. So this is really the kind of the last thing I want to talk about here, which is building a system that works, the step-by-step way to get everyone on the same page, and this is a lot of work. And, I noticed this when we were talking about developing crisis stabilization centers all across the nation. People they think, oh, I'll just develop a crisis stabilization center and it will just work. And it's like, no, you have to put in a lot of work getting everyone on the same page. And it's stakeholder engagement. It's building a shared vision and a roadmap. It's, looking at the data together. It's trying to standardize policies and protocols across different agencies, sometimes with different core values. But it's really important that you think about what do the people in my community actually want and need, and how do we align with that? And the future of healthcare belongs to that. The future of healthcare belongs to the providers that respect and listen to the users of service. It's like any other service or business in the private sector thinks this way. We have to start thinking that way too. And then you start thinking about what your shared infrastructure would be like. And then, piloting and continuous improvement, stakeholder training, capacity building, pilot launch and data monitoring. How is our integrated system of crisis care working? And then you start looking at sustainable funding strategies together. You start saying, okay, let's build this out. And I think that's how communities generally do this really well. You know, we've gotten some good input into 988 and our call centers from the federal government, and maybe the next step is really thinking about, are we supporting our mobile teams? Are we supporting our crisis stabilization centers? Are we supporting our short-term crisis residential services? So that's generally, you know, the work that is hidden, that is really hard to do, and that takes a lot of hard work to and time to do before things work effectively. Next slide. So there's my contact information. Again, it's you know, anyone with any questions, if we don't get them in a day, you can reach out to me. I'd be happy to talk about any of this. It's a real passion of mine. I love the topic, and I will turn it back over to Elon. Thank you all.
Thank you, Josh. Thank you very much. It's a lot to take in and such meaningful and powerful information. I want to acknowledge the abundance of questions we're receiving in the chat. We will make sure to address some of them as well. And I want to make sure that we actually infuse the content with some of the questions that you guys have, because they're wonderful questions that have been asked. A few of the things, just to parlay us directly from what Josh mentioned, I think that one of the challenges before we even get community involvement in determining NIMBYism or all those other things that may come up with putting together residential programs, whichever type you may see within your facility, within your states, is buy-in from the states, the providers, and the stakeholders themselves as to the continuum of the network that's available. And what I mean by that, and let's move to the next slide so we can compare and contrast a little bit of this, is we need to be mindful of what services are available and that they're not competing with each other, that there are different levels of care and different services that should be available and accepting of all people throughout the entire system. One of the phenomenal questions I noticed in the chat that I wanted to speak to was the idea that some of the data pertaining to peer respite programs may be skewed due to the fact that they may be weary of letting people go into a higher level of care, such as locked hospitalization. Some of the data around 23 observation may be skewed as well because of the idea that they need to push people out the door at the end of that period of time for stability's sake. And some of these data around crisis residential treatment may also be skewed because people have an objective and a mission in mind of ensuring that they are part of the national continuum of crisis care as well. I think what's very important, and maybe this is one take-home message from the totality of what we're speaking about today, is that we need to view all of these things as part of one continuum where we are all working together and not competing against each other when it comes to crisis care. That each of these levels of care could be available and useful within your state, within your locality for the clients you service. It's about determining which one may be the right place for them and which one may be the place that is going to accept them now, not thinking of them as competing with each other, but rather collaborating to keep people out of alternative systems of care. What I wanted to start by sharing on this is that a lot of this idea started around roughly 1963, when President Kennedy signed the Community Mental Health Act, which was moving people back into the community, back in with their caretakers, back in with their caregivers, rather than keeping them locked in facilities. And in that period of time, there were places, and they have even existed prior to that act being signed, such as Soteria House, which is a residential treatment program that was a home-like environment that was unlocked and voluntary, where it seemed paradoxical at first, but people were staying there receiving treatment who may have had high-risk thought disorder behavior, but they were offered either medication-free or limited medication supportive services in that environment, and it showed some efficacy related to their time in that facility as compared to in a hospital setting as well. So while in the next few slides, I'm going to compare and contrast crisis stabilization services and crisis residential treatment services, this is in no way, shape, or form to disparage one system of care over the other system of care. It's to identify the benefits and the drawbacks of each system and realize that this must be a continuum of services for all of us to have within our localities, rather than to view them as diametrically opposed to each other or jostling for space within the 988 continuum. Just to start us out here, and give us some level setting of again, definitions and information. 23-hour observation units, or oftentimes crisis stabilization units, CSCs, utilize the term chairs for the space that's within the program. So a person who is in that program is not necessarily defined as being in a bed. They are given a chair because that is not a residential facility in the colloquial term of they're sleeping there ongoing for several days. They may be there for that observation and treatment component period of time, as compared to crisis residential treatment, which may be slightly longer lasting, as Josh mentioned when it comes to peer respite services as well. So to start us off, one of the key distinctive differences is going to be, crisis stabilization units are going to have objectives that are short-term, highly intensive, focused on immediate safety and stability within that setting to assess the individual for whatever their level of additional care in terms of a robust outpatient system that may be available is going to be able to support them. And in lieu of there being that massive, robust outpatient system, which in many places there isn't, there's a struggle to get people into ongoing care, there are residential treatment facilities. These are medium-term programs in terms of their intensity. They're going to offer support, transitionary support in a home-like environment with therapeutic aspects in it. They're going to keep people in this environment for several days longer, a little bit more time to decompress and decompact within their care, and determine what may come from that next as well. So moving along and looking at the following slide, I wanted to give a little bit of a guideline to what the crisis stabilization guidelines were determined in the original publications of the guidelines for crisis care. The idea behind the crisis stabilization units was a facility that accepted all referrals, did not require medical clearance at first, had a co-occurring service design with staff who were there around the clock, 24 hours a day, 365. These staff are going to be credentialed. These staff are going to have the capacity to observe individuals, assess individuals, triage individuals, and then also offer them different services in terms of where they can go next to receive the rest of their care. That may be determining that they go into a outpatient program or offering them referrals to outpatient programs. That may be placing them back within their communities as well. But these programs were also designed to be able to be a dedicated space where first responders may be able to drop individuals off and incorporate them into the community where they are part of a real-time national registry of beds that are available so that people from 988 call centers or people from mobile response teams can utilize them as a location and a resource to place them in. The idea behind this as well was a location where you can coordinate and connect the person's ongoing care, whether that care is sending them to a locked hospital facility or placing them back within an outpatient system or environment as well. I want to juxtapose that on the next slide with a little bit slightly different of an approach when it comes to crisis stabilization systems, as well as tapping into some of the information that was sourced from a National Council white paper, and also an organization called TBD Solutions, which put together a best practices guideline for crisis residential services as well. Within this system, we want to take into consideration that the crisis stabilization units, as compared to crisis residential facilities may not accept every person who comes through their door. They're going to accept appropriately screened individuals that are at the right level of care for them to be able to handle. They're also going to link the person to additional medical resources and supportive services that are available for them. These two also have 24-hour programs and designs. And within these programs, they're going to take a person-centered evidence-based practice design and approach, meaning that they're going to take into consideration the holistic individual that's in front of them, whether that person is actively clinically detoxing from a substance, not medically detoxing, but clinically detoxing from a substance, needs support when it comes to substance treatment resources or harm reductive resources, needs support when it comes to medical physical care as well, and needs support when it comes to those other aspects that keep pulling them down into the system. The utilization of a residential program, which has a little bit more time in it, allows you to tap into more locations as resources to keep the person out of a hospital and keep them out of a higher level of care that may not necessarily be needed for that individual. So let's take a look for the moment at the next slide, which is going to be an overview of the crisis model, the crisis residential model. Let's just click through because I know that there's a few clicks there, and then we'll end with one. Perfect. Thank you very much. In this model, I wanted to share a little bit about my background and my history and the work that I've done. Working in Los Angeles County, I've worked for Didi Hirsch Mental Health Services for roughly the last 13 years of my life, where at Didi Hirsch, we have had crisis residential treatment facilities longer than I have actually been alive. These programs have been around for longer than I have existed on this planet, which is phenomenal for LA County and for Didi Hirsch Mental Health Services. The programs at Didi Hirsch are short-term, they're home-like environments, and they're going to be a location that is going to serve as an alternative to a hospitalization, or in some spaces, a step down from hospitalization as well. In these programs, individuals are going to receive acute behavioral health support because they are coming with acute conditions. These conditions can range from anything in between thought disorders to suicidal ideation and homicidal ideation, all the way across to mood disorders and substance impairment or substance support as well. The short-term intensive supportive services that they're going to be offered are going to be given to them in a home-like environment that has a social rehabilitation component to it. The programs that we offer at Didi Hirsch, for example, have a capacity for individuals to remain in the service for up to 28 days, which may be substantially longer than many other places within the United States. However, it is a week-by-week assessment of their care, which means that people are not given 28 days of residential treatment. They are given 7 days of residential treatment as an initial authorization, and on a week-to-week basis as a determination if they continue to need that level of care. Now, what's phenomenal about that service and the way it's designed is it places an emphasis within us as providers to identify all of the resources that they may need to be able to thrive out of a residential facility on their own, in their homes or in the community within a week period of a time. That may mean finding out if they're struggling with food insecurity and getting them food resources that are available, getting them an appointment for an outpatient location, finding a pharmacy who's willing to refill their medication if they choose to and have medication, getting them on medication-assisted treatment, which may be the first time that somebody's offering that service to them outside of a hospital setting as well. That week period of time gives the person the ability to rest, recover, and restore while resources are being determined for them. One of the quotes that I really love to pull from is from Steve Fields, who is the executive director of Progress Foundation in California. He talks about the idea that if you don't have in your county a fully staffed crisis residential program, then what most likely is happening is you are hospitalizing people who do not need to be hospitalized. And I think that is one of the tenets, again, that we can all agree to within this entire system. Whether we call it a crisis residential treatment facility, whether we call it a crisis peer facility, whether we call it a crisis respite, peer respite, or any of the terms that we may use in between, the idea is to place people in the least restrictive level of care with the most humanity and human services around them. And I think what I would like to add to this before we move to the next slide is a little limerick that was written by a client who was in one of Didi Hirsch's crisis residential treatment programs in the past. They said, "In crisis, we may feel quite alone. Our minds and hearts can feel like stone. But with support and care, we can mend and repair in a crisis residential treatment home." The idea of home being that place where they're going to be able to restore and repair themselves and bring them back to what they need. So if we move to the next slide, I'll talk a little bit more about the objectives of crisis residential treatment facilities that we've incorporated, particularly in the programs that are located here in Los Angeles at Didi Hirsch. We start out by developing and implementing an individualized stabilization treatment plan for the individual. This means that a person is coming into our program with a comprehensive assessment provided to them of all of the totality of what they can provide us in terms of information. That information may be information that we're accessing by their loved ones, their peers, the people who've referred them to the services. That information may be given to us by a hospital who is stepping them down out of a hospitalization and service as well. They are then given, for the purposes of the treatment billing model as well, a diagnosis and a treatment plan that is individualized based off of what is going to be needed to help stabilize them. What they're informed of is that this is not a place where all of the issues and concerns that they've experienced are going to go away within the short period of time that we have. If you think you are going to solve the chronic housing problem in the United States, and especially in Los Angeles or in California as well, in a short period of time, then we are setting the people who are receiving our services, whether we call them guests, clients, or we call them patients, up for failure. What we need them to be aware of is that we are here to help resolve the current crisis that may have led them to this level of care and move them to the next person along and connect them with those community resources that may be able to help them as well. So within the programs that we operate at Didi Hirsch as well, what we are offering them in this location is going to be the opportunity for symptom reduction and the opportunity for behavioral stabilization. What that's going to look like is that they are going to have access to see a psychiatrist or a prescriber on a weekly basis to adjust and modify their medications if they want to. Oftentimes, we have found that the ability to see a prescriber more than once in a short period of time, where the prescriber is not pushing medication on you, oftentimes leads to higher results when it comes to actually taking the medication and continuing to utilize medication that may be needed, particularly medication around medication-assisted treatment for substance use concerns. In this environment, they're seeing a therapist, a clinician on a weekly basis. They're working with professionals and paraprofessionals and peers within that system as well to connect them with a group of individuals who are living in that program with them in a community-based setting. What that means is that they are going to have access to group on a daily basis several times a day. Groups that are designed around evidence-based practices or evidence or community-based practices that are going to help the individual create self-efficacy in the problem area that may have led them to where they are to begin with. Supportive services such as DBT that are going to embed coping skills and coping mechanisms into the behavioral support, and supportive services like RAP, Wellness Recovery Action Plan, are going to be embedded in the program to allow the person to not need to fall back into the crisis system of care as well. So if we can, let's move to the next slide. And I want to compare again these crisis residential treatment facilities with crisis observation facilities or CSUs. And again, I'm speaking more to crisis residential treatment because that is where I have spent the majority of my career and my time. But in many of the settings here, we've had clients go from a crisis observation unit to a crisis residential because they needed something else, or vice versa. Each service can be the right service for the individual if we understand what they're looking for. Both facilities are going to be able to accept referrals roughly 24 hours a day, 7 days a week. Both facilities should be able to accept all referrals and triage all those referrals. But what they do need to know is to be able to individualize and differentiate between what they can handle and what they can't handle. Both facilities are going to include prescribers and clinicians and nurses and peer support and professionals who are going to be in those environments to help individuals as well. And both places are going to be a diversion or an option away from a psychiatric hospitalization or away from incarceration for the individual as well. What I want to talk about on the next slide is just a sample overview of staffing models for crisis residential facilities. And again, this is a model that you see on the screen in front of you, which is the California policy. This does not reflect the entire policy of all types of residential services. But in our program and facility, for example, we will have a program director or a program manager or a program coordinator, whatever term we want to use, for somebody who oversees the staffing and the people who are in the program. We're going to have a therapist who is there to help provide ongoing clinical support. or a substance counselor who is going to offer that care and support as well. We're going to have some type of consulting prescriber who is going to be there to offer suggestions when it comes to collaborating with psychiatry, but not necessarily pushing psychiatry as an agenda. There are going to be paraprofessionals or professionals who are in this environment who also are going to either be case managers, care coordinators, or peer advocates who are going to offer the clients all of the different types of services that they may need to bring them into the right level of care beyond the time they spend in a residential facility. The example I use here in terms of staffing patterns is a California pattern. The idea here is that you need to have a minimum of 2 staff members on shift all times, and you need to have a peak staffing ratio of roughly 1 person for every 1.6 individuals in the home during the peak hours of the day. What that looks like is that many of these facilities have a capacity for 16 beds in the state of California. 16 beds would be the capacity for these programs. And you would need to have roughly 10 staff in that peak period of time for every one of those clients in a full comprehensive house as well. In discussing the staffing model, the model that you see in front of you is a model that I want to overlay for a moment into a cost-based model as well. So I'll share with you a little bit of this out loud, so I don't have a graphic for it, unfortunately. But in Los Angeles County, if an individual goes into crisis and is then taken to an emergency department, and from an emergency department, they are then taken into a psychiatric hospitalization, remaining in that psychiatric hospitalization and that emergency room for 15 days, what we find is that the total cost for that length of stay is roughly $30,000, if not more. If we take an individual through the crisis residential pathway that I just mentioned, where they still are in crisis and are taken to a CSU or an emergency room, but after that emergency room, instead of staying in that environment, they are transferred rather than to a psychiatric hospitalization because they do not meet criteria and don't need to be in a locked facility, to a crisis residential facility, and they remain there in that period of time. That entire length of stay is going to, on average in the state of California, cost $9,000 instead of the $30,000 that I mentioned above, saving the system of care 71% versus an inpatient environment. Now, if we create the totality of the services that are defined within the 988 umbrella, which are going to be a place to call, person to respond, and a place to go, then instead of a person even needing to go to an emergency room department, a person in crisis will call 988, a mobile response team will come out and assess them, a mobile response team will then take them to a crisis residential facility where they may stay for the same length of time I mentioned above, of 15 days. And the entire system of that model of residential billing will roughly only be $6,000, which is, again, on top of what we mentioned previously, a 71% reduction in inpatient costs. This will be an 81% reduction in inpatient costs. What we have found through some of the data that we've put together with the Los Angeles Department of Mental Health as well, is that on average, if a program diverts 400 people away from a hospital on a given year, then you're saving the system of care roughly $25,000 a day, and you are annually saving the system $9.7 million in terms of treatment. That takes into consideration the staffing model I just mentioned. This staffing model can be run and operated within that budgetary saving that I just mentioned. This in no way is to suggest that we shouldn't have emergency room departments that take psychiatric patients, psychiatric hospitals that take patients, CSUs that take patients or clients either. It in no way is to suggest any of those things. It is to suggest, again, as we mentioned by the initial quote, that without having a robust system in place, you are likely placing people within a level of care that is higher than the level that they may need and doesn't divert them out into a setting that is going to offer them the least restrictive services, which oftentimes end up being the services that they're most likely willing to agree to take on and work with. Let's move to the next slide as well. Let's talk about what we just mentioned as well in terms of a realistic alignment of some of these things. Let's just click through so we get both graphics on both sides. Wonderful. Thank you. So within these environments, the 23-hour observation facility is going to be a place that is going to accept everyone. Whoever gets dropped off there is going to be receiving shorter term targeted treatment that is going to include the ability to support them. But, and this is a small caveat, some of these 23-hour observation locations, because of the fact that they must include everyone and accept everyone, might also need the utilization of seclusion or restraints. That is not what they would say is the frontline defense of treatment. That is not what they are going to offer as going to be the beginning stages of care. But when you have a system that must accept everyone, oftentimes you end up having to include some form of seclusion or restraint system in place to allow everyone who's in that program to be safe. Now, many of those people need that level of care and need those services, but an alternative for that at times may be a crisis residential program, where a person is not going to be in an environment where there is going to be seclusion or restraints, is not going to be in an environment where that is going to be part of the system of care. However, they may not get as targeted one-on-one attention because there are going to be more people within that facility who in those programs need to work on their own services as well. That's going to include psychosocial rehabilitation services and other aspects as well. The aspect that aligns these services really effectively with each other is the idea that these are both environments where we hope people who need medication or need to start medication are going to be able to get access to that care. These are going to be environments where the removal of the person from a stressful environment is going to help the community and help themselves regulate and reset. They're both also environments where they're going to be able to set and execute short-term goals for themselves. In 23 hours, there are goals that can really be accomplished, such as getting a person to agree to the next level of care or services, getting them to review and look at the resources that can keep them out of these types of systems in the future as well, and provide them with safety plans or perform a risk assessment that is going to be vital and needed as well. Both of these are going to be really important components of both the crisis residential services and the crisis observation services, observation support as well. Staying on the slide because I want to mention this information as a refresher to bring us back to what we mentioned really originally on some of the slides up above at the beginning of the presentation as well. We talked about the idea of this comprehensive system of care. We talked about the idea that the comprehensive system of care is a place for someone to call, a place for someone to respond, and a place that someone is safe. And I want to mention that this means that there has to be harmony across these systems of care. People who operate peer respite programs oftentimes find that what's most important is to keep a person out of the least restrictive level of care. It may not be as important to them to say that it's the appropriate level of care, but it's the least restrictive, and that's the environment I want to place them in. I want to emphasize for a moment that we need to filter those two things simultaneously with each other. It can't just be the least restrictive, because at times, the least restrictive may not be the safest for everyone else who's involved. It has to be the most appropriate level of care. But the reason that we struggle with determining and threading that needle between least restrictive and most appropriate is because we don't have an encompassing system in place where all of these services are robustly held at the same platform. What that means to say is if we know that within our locality, within our community, we have crisis centers, 23-hour observations, emergency rooms, psychiatric hospitalizations, crisis residential treatments, and peer respites, with all of those things accessible to us, we can then make a better determination or an estimation of what is the appropriate level of care, what is the safest level of care, and what is the least restrictive level of care. But all of those have to go in hand, and oftentimes we cannot make that justification without the total system being in place. And therefore, you may find people in a system that's more restrictive than needed, but you also may find people in a system that is not offering them the appropriate level of care because we're just trying to keep them out of the most restricted setting. It's this catch-22 where unless all of these services are placed on equal footing, you're going to find that constant struggle and shift between each of them jostling for the client should be in our setting because our setting is either more targeted or our setting is less restrictive as well. And I'll end with sharing a little bit on this topic that I think is going to be really important based off of the idea that many of the people who offer these services themselves have been surveyed by the National Council of Mental Wellbeing. The National Council did this Harris poll a little over a year ago, where they looked and saw that they were seeing a massive exodus of mental health workers and substance workers from the field. In that survey, they found that roughly 9 out of 10 behavioral health workers were concerned about the ability of the people they treated to receive services, meaning that they felt that 90% of the people that they were servicing may have another crisis in the future because the system wasn't robustly available to support them. They also found that roughly 9 out of 10, 93% according to the National Council survey, said that they were experiencing major burnout, which was leading them to consider leaving the field. Nearly half, 50% of the individuals surveyed who were working within the system of care, indicated that workforce shortages, struggle with self-care, struggle with taking care of themselves, have led them to consider alternative forms of employment rather than working within this system. And I think what's really important, again, is to go back to what we just mentioned, which is we can't just think in a silo of the system of care that we offer at our location. We can't just think within a silo of the system of care that we think is the most appropriate. We need to take into consideration that there may be a program that offers a restraint that is appropriate for an individual, and there may be programs that don't offer restraints that's appropriate for an individual. We need to know within our areas, within our localities, what program is best going to help an individual and what program is going to sometimes not be the most effective place of care. And with that, knowing that we have a robust group of individuals here, I want to take a moment and just share what I think would be really beneficial for those of us who are considering this line of care and also are interested in making sure that the people we service in these communities and the staff that we keep are also taking care of themselves as well. And I'll end with another story or quote as I started with as well. And if you've heard this before, please bear with me because I think it's a really powerful thing to share. There are two lumberjacks who on a daily basis go out to the fields and they go start their work of cutting down trees every single day. They start at the exact same time and they end at the exact same time every single day as well. Lumberjack 1 spends his time chopping down his wood, but in the middle of his day, he takes an hour break every single day and leaves. And Lumberjack 2 continues on his day and doesn't take that time off and doesn't take that break. And day after day after day, the first lumberjack, the one who takes a break, always ends up chopping more wood than the second individual. And finally, one day, our second fellow asks his friend, I show up to work at the same time as you every day. I leave at the same time as you every day. I work an extra hour on top of what you work every single day. And yet, you end up producing more than I do. What gives? What do you do in that hour that you take off that leads you to be able to chop more wood than I do every single day? And the first lumberjack simply answers by saying, oh, I take a break and I go home and sharpen my axe. The idea of us understanding effectively that we too need to step back sometimes and take care of ourselves to better think of the model of care, to better think of the self-care that's needed of the individuals we're servicing as well. It is not a failure on our part to be able to identify the pros and cons of what services we offer as compared to the other services that are available. It helps us better focus in on what is best for the system by being able to take time and reflect, sharpen our own instruments, and then go back and offer care as well. So I want to thank you for the time that you've spent with us today. I want to send us to the next slide, which has some of the references and works cited that we've gone over during this period of time. And I want to take the time to be able to thank again our hosts here today for having us here and allowing us to present on this information. However much of this information may be specific to our own awareness of the model of care. And then take the time that we have left to go into an abundance of the questions that you may have asked within the chat that we didn't get a chance to address as well. Thank you very much for being here. We hope to be able to answer as many questions as we can, the ones that have been given to us so far.
Yeah, all right. Thanks, Alon and Josh, for that fantastic presentation. My name is Matt St. Pierre. I'm a director with the National Council for Mental Wellbeing. And boy, the chat's been active today. We have a ton of questions for our presenters, so I want to make sure we get to as many as we can. And if you have more, please do put them in the chat, and we will try to get to as many as we possibly can before the top of the hour. So first question was from Vanessa. Can you speak to which types of settings might best help someone with the need for substance use treatment?
Yes, I think I can speak. I think I'll start by speaking to that, and then I'll pass it over to Josh as well. So,
Sure.
Hi, Vanessa. Thank you for asking a question. One of the benefits that we have seen individually, we have seen ourselves within the difference between crisis stabilization units or 23-hour observations and residential treatment is the ability to get people access to, or at least appointments to discuss medication-assisted treatment. In 23-hour observation, we do know that medication-assisted treatment is offered to the individual, but oftentimes in that first 23 hours when they may be clinically detoxing from a substance, it may be difficult for them to comprehend or take into consideration that medication-assisted treatment may be useful and available to them. And therefore, the idea of being able to assess them in a crisis residential program and ask them questions about medication-assisted treatment, but follow that up several days later, we end up finding that there is a higher efficacy of individuals who will be buying into the utilization of that. And in a longer term treatment program, such as a crisis residential program or a peer respite program, you have the ability to have individuals in those programs who are going to offer them the rest of the resources that are part of the substance continuum. Whether that may mean groups like in our programs, bringing people like AA or NA in to offer care, bringing individuals in to offer fentanyl test strips and provide Narcan to every person who leaves the facility. The more time you have with them, the more of the ability you have to tap into some of the underlying mental health concerns that may have exacerbated or led to their substance problem. Anything I missed on that, Josh?
Yeah, I've seen the substance use equivalent of peer respites, or maybe not peer respites, but just short-term residences. We have one locally in my region, and they were actually a very committed partner when we were developing our crisis stabilization center. But I think my ultimate idea, maybe an answer to that, would be to bring some of the principles and practices of what we spoke about, or what I spoke about. I don't want to speak for Elon, and apply that to detox and rehab, and really try to raise the bar on those types of services, because I think that if we could maybe all learn from each other, we could make it maybe more engaging and people more comfortable and more willing to stay longer. And of course, payers need to pay more for longer stints at especially rehabs. We're not effectively addressing the issue in 21 days. So I think it ends up probably costing the system way more money as well to not let people stay longer. But that would be my only addition.
Okay, I'm going to keep us moving here. What about training and quality per crisis center? So like the question is from Nina, and she asks like kind of who oversees training? Is it management? Is it a particular board? Is there another overseer that has experience that kind of looks at that?
You want me to go, Elon?
Go ahead, Josh. I'll go after you.
Yeah, in my experience, management definitely oversees training of. I'm assuming we're talking about the internal operations training of staff. Yeah, definitely management would be overseeing that. In larger organizations, you have pretty sophisticated HR functionalities too, where, I've talked to some organizations that have people in charge of just the leadership development even of an organization. So, but I think an engaged board would definitely be interested in that. But I don't think they'd be overseeing it. They'd probably just be guiding the senior leader of the organization in how he, she, they want to filter that down.
I'll add to that in different states and in different spaces, there are licensing bodies that oversee each of these types of programs that determine the minimal threshold when it comes to training for staff members. For example, in California, there's a minimum threshold of 20 hours of crisis training for people who are going to work in those facilities to determine that they know the information around how to do an admissions procedure effectively, how to do crisis services effectively, how to assess for suicidality and things of that nature. And I also know that quite recently, a group out of the University of Wisconsin is working on creating a training module and a training metric for crisis services to ensure that everyone has universal crisis training, so that it's not something that is just specific to each location, but you can pick an individual up from and pluck them out of Josh's space and bring them here into Los Angeles, and also ensure that they are going to be able to offer those quality care as well.
Okay, and be sure to take a look at the chat, because the chat's got lots of love for everybody in it. Next one. All these things seem to assume that some entity has funding for the physical space for this service. Are some areas and insurance providers more generous than others? That's from Barbara.
Yeah. May I, Elon?
Go ahead. Yeah, this is your space.
Yeah. In my experience, yeah, that's, the idea that I was talking about larger systems like Medicaid, there certainly does need to be some sort of buy-in from, it can be state government, it could be local government. That's where you, and also obviously the other types of funders you have, it could be private or corporate foundations where there is a connection, or some people have some sort of shared experience. It doesn't have to be personal experience, it could be a loved one that went through things like that many of us have gone through in the past, crisis and recovery. And so it's really important to think about that question. Where do you get the so-called capital, right, for bricks and mortar? And the other thing that we found in New York State, where we're doing the 1115 Medicaid waiver, is that Medicaid does not want to pay for room and board. So you have to sort of carve that out as well. So there has to be some sort of commitment from other funding resources, but the majority of the funding for the service in New York, as it is right now, if you're using that Medicaid waiver, is coming from that. So it's not a huge burden ultimately, but the building itself can be definitely something that you need help raising money for. And I think it's a great use of state or local resources if you have it as part of a broader plan, and it's going to be, again, helping the overall people and the overall system that make up your community.
I think I'll add to that one of the novel approaches that many states have taken, including mine here in California, is going and partnering with the hospitals themselves and speaking to them about any physical land they may have available or space that they may have available to turn into one of these programs, whether it's a crisis residential unit, whether it's a crisis stabilization program, or any of the other terms that we've used thus far. Because the hospitals themselves benefit from diversifying that as well, and keeping the right people in the inpatient units and the right people within these crisis programs as well. So you can reach out to several of the places that are the big hospitalization providers in your space and check with them and partner with them to be your own entity and agency who may operate physically within a space that they have, which gives them easy access to a step down for your program. And it also gives you the stability of knowing that if you need to place a person in a higher level of care, which you do sometimes, and that is acceptable. People do sometimes need that higher level of care, whether it's a locked facility or an inpatient, that it's going to be a mutual partnership that you have, because both of you are going to be helping support the community. And I also know that there was something in the chat about a little bit of the NIMBYism behind that. And I think that that's part of how you can address it as well. Knowing that it's already within the physical space that may be encompassed by a hospital or a medical campus, rather than placing it somewhere else, could be an inroads into allowing the community to be comfortable with it. And then eventually, when they start seeing the benefit from that, you might be able to start branching out even further into the community if you are experiencing any of that stigma as well.
Yeah, I can speak to the NIMBYism. I've been involved in many of those fights. And, you know, the irony of the service is that it is run by an organization typically, right? Like a 501c3 nonprofit or so a healthcare provider, right? But so it's a commercial type of issue, but the benefits and the magic of the service lies in the fact that it's in a home-like environment, so that it often thrives in residential communities. So at least, you know, like what I always say to people, if you can find mixed-use zoning, that helps a lot. And then it's just like Elon said, it's a lot of education and a lot of patience about teaching people about it. And then sometimes, you know, obviously you do have to get some legal assistance involved too, if that's not working, because, you know, it's some of that is societal stigma or discrimination, and then some of it's obviously valid as well, I'm assuming. So you got to make sure you know where that line is. You know, I don't know where that line is personally, so I try to always bring in experts to help out with things like that.
Then I'm going to try and wrap up several questions into one question since we're running out of time. But there was questions about, like, essentially, where can I learn more? Like, there was a question about appropriate criterion for these. We've talked a lot about how these are great alternatives when appropriate, right? So, like, what are the criteria for a 23-hour observation, an RCS, RCT? You know, where can I learn more? What resources are there? So, just we have the works cited page, which obviously has a lot of resources. And not to plug the National Council, we have stuff on there too. And so, but are there any other resources, Josh or Alon, that you would want to think of, or people could learn more?
I know Elon's involved with one excellent organization.
I can speak to one that then bifurcated into two. I work closely with Crisis Residential Association, which is you can access them. You can find their website, cra.org or crisisresidentialassociation.org, which has quite a bit of information, not just on crisis residential treatment services, but also the entire umbrella of care. But if I can make a little just plug here for this as well, there is a national crisis continuum conference that happens on a yearly basis, and it's at year 2 right now, CrisisCon. CrisisCon is going to be taking place in Phoenix, Arizona this year in the middle of October. I believe it's October 14th through 17th. You can look at their website by going to crisiscon.org. And the entirety of all of the systems of care that we discussed, whether it's from the beginning of crisis call centers to mobile response to all of the residential programs, are part of this association and part of these 3 days of learning when it comes to these types of facilities. Anything ranging from how to even include faith-based into these organizations, or to take substance focus as well into these organizations. So either of these resources, inclusive of the phenomenal resources that I know Matt mentioned that the National Council has as well, and the consultants that National Council can offer to the people who are members as well to utilize those services, that's another place. And then lastly, it's tapping into people that you are seeing and meeting in the chat here as well. So many of you have been speaking to each other in the chat and checking in with each other. The resources that may be difficult to find might be something that you can find by finding your other crisis warriors that are out there and reaching out to each other and asking them about what worked for them, so you can take that and bring it to your place as well.
Josh, anything to add?
Yeah, state resources too. You know, the Crisis Residential Association definitely collected a lot of people together. You know, Bevan Croft and Leisha Ostro's work is a great unifier. In New York State, we have, you know, the Alliance for Rights and Recovery, with formerly NIAPRS, and many of you know probably Harvey Rosenthal is somebody that's very connected to what's going on in maybe the vanguard, so it's always good to stay in touch with some of those larger connective tissue organizations. The membership organizations, like also National Council is just invaluable in that regard.
Well, I want to be mindful of time, so I want to thank our presenters, Josh and Alon. Thank you very much for the fantastic content today. I'm going to toss it back to Nashville to close us out.
Great. Thank you so much for the wonderful presentation. That does conclude today's session. You may now disconnect.
Thank you, everyone.
Thank you, everyone.